and then I hope it will be your pleasure to adopt our subcommittee report.
Thank you, Delegate Garrett. Susan, good afternoon.
Good afternoon, Mr. Chairman and members of the committee. I'd like to start today on page 2 of your packet with the report of the Health and Human Resources Subcommittee. The healthcare recommendations begin on page 3 of your packet. There is an amendment to House Bill 29, which increases healthcare coverage to uninsured Virginians, as Delegate Garrett alluded to. Thank you. It assumes an effective date of January 1, 2019, with about 300,000 individuals that are projected to enroll in the program. It incorporates the innovative reforms to promote health and well-being, personal responsibility, and fiscal sustainability. As Delegate Garrett indicated, the language creates a dual track for Medicaid transformation through a Section 1115 waiver demonstration. So within 45 days after passage of House Bill 29, Virginia would submit state plan amendment application and file the initial paperwork for the demonstration waiver. Within 180 days of passage, Virginia will submit a completed waiver application for reforms. The language requires that there is involvement of the money committees in discussions with CMS and provides for progress reports. House Bill 29 also provides the funding that Delegate Garrett indicated. It's $3.5 million general fund dollars and federal matching dollars for DMAS to hire an expert with successful experience with similar waivers to assist with the design and the approval process. House Bill 30 also, as indicated by Delegate Garrett, contains funding, $4.6 million in 19 and $16.9 million in 20 to support the TOP program. Continuing on with some more specifics, Delegate Garrett alluded to most of these. It does incorporate the TOP program. The only slight change is the participation hours were converted to monthly rather than weekly requirements to be a little bit more administratively easy for tracking purposes. It does use a premium assistance model with a health savings account to put individuals on private insurance plans or employer-sponsored insurance. The premiums would apply to those with incomes between 100 and 138% of the federal poverty level. It does include cost-sharing provisions for enrollees to pay premiums and co-payments and ensure personal responsibility. It includes incentives for healthy behaviors. It does have provisions so that participants may be suspended after a grace period if they fail to pay their premiums or fail to maintain continuous coverage. And it includes provisions to disenroll if federal funding is reduced or terminated. The costs are listed here on page 5, but I'd like to sort of take you over to the next page where you can see them in a table. I think it'll be a little bit more explanatory. The costs are listed on that page. You've seen something similar with the introduced budget when I went over this earlier this session. The costs are covered by a provider assessment on private acute hospitals. And there's language in central accounts that provides DMAS with the authority to impose the assessment. The revenue would be deposited into a lockbox in the Virginia Healthcare Fund. The total savings, as listed in this table, are projected to be $101.3 the first year and almost $270 million the second year, and that does include some of the DOC savings as well. Those savings are based on the elimination of the general fund dollars for many of the healthcare programs that are already paid for through our existing Medicaid program. Some of the other DMAS and Medicaid spending items that are included in the packet before you is a 1% personal care rate increase for both consumer-directed and agency personal care. That's almost $5 million. Medicaid costs for CSB same-day access to services. A restoration of the dish payments for Catawba Hospital and Piedmont Geriatric Hospitals. This is due to action by the that came out of the Bipartisan Budget Act that was just passed. And there is funding to streamline enrollment of DOC and jail inmates in Medicaid. Going to the next page, again, you saw this slide a little bit earlier this session, and it's been adjusted for some of the spending that was added. And I'll just go to The next one, DOJ settlement agreement. This you've seen before. I just wanted to make sure that you saw it again, how much money. There's about $32.4 million in the budget for the DOJ settlement agreement. In terms of community behavioral health services, this slide is about $54.2 million, and it does reflect the addition of 6 drop-off centers that would go into rural, unserved areas of the state. That continues an initiative that this body has had for a number of years. In terms of the behavioral health services, again, this table is fairly similar to what you saw earlier, but the funding that was needed to backfill the loss of DISH funds was removed, since that is now going to go forward, and you saw the Medicaid adjustment for that. In terms of the TANF program, as you will remember from my presentation earlier this session, the TANF spending continues to exceed the block grant amount, or TANF exceeds the block grant amount, leaving a balance of $94 million by the end of 2020. The caseload decline is really due to the reason why we're accumulating balances so quickly. So there are a number of new spending or continuation of spending initiatives that you've embraced in the past that the subcommittee is recommending. The first is to add funding of $3 million each year for community employment and training programs that are provided largely in the cities that have come forward in the past year to do some innovative programming. This would add to that pot of money for a second round of grant recipients and would widen it to some of the other localities, rural localities that would have initiatives as well. There's $2 million in 19 and $4 million in 20 for a 2-year pilot at the health department for access to subcuticular contraceptive implants. It does require metrics and a report on the pilot program. There's $2 million for community action agencies, some funding for domestic violence programs and child advocacy centers that you've funded over the years. And there's some funding for Early Impact Virginia. This is the home visiting consortium to do some additional monitoring and tracking. And I think I've got a little repeat on the bottom of that slide, so we'll just move on. Major savings in Health and Human Resources. There is $42 million that was identified from congressional action to place a moratorium on the ACA health insurance tax for a year. We'll pick that up in the second year of the biennium. Again, savings from the training center closures and discharges. The subcommittee is also recommending a delay in hospital inflation until 2020, so it picks up savings in the first year. In terms of, there's also additional savings from reducing the rate increase for the CD personal care. Instead, what the subcommittee is recommending is that we provide a rate increase for both consumer-directed and agency personal care of 1% in the second year of the biennium. The other item there is to eliminate overtime for consumer-directed personal attendance. That's consistent with what this committee has recommended in the past several years due to concerns that we would be considered an employer of record. There's a delay in the health department initiative to implement electronic health records until 2020. And then training funds for CD personal attendance was eliminated. And funds for the meningococcal vaccine, that was a bill that was defeated. And that concludes the report from this subcommittee.
Do we have a motion to receive the report? So moved. Have a second? All in favor, please say aye. Aye. Opposed? All right. Thank you. Delegate Peace.